Okay, so let me introduce our next presenter, Dr. Jennifer Foster. I want to tell you that Dr. Foster and all of our presenters today, really, they do this volunteer. So they volunteer to come in on a Saturday morning, and probably more than that is the time they spend getting this presentation together. So I know Jennifer will give you more of a background of her work with the college and with Nebraska Medicine. So please help me in welcoming Dr. Foster.
Good morning. Is this on? Can everyone? Did I not turn this on? Do I need to do something?
I'll try.
Okay. Oh, much better. Okay. Good morning. Thank you, Judy. So as Judy mentioned, I am a pharmacist. I work at Nebraska Medicine. I work in ambulatory care, and I've been a pharmacist for about 24 years. Prior to being a pharmacist, I was a pharmacy technician. So I also just want to say thank you for what you do. I've been on both sides. I know what you do, from the standpoint of doing it myself, and I know what you do from the standpoint of a pharmacist and how you help me do my job better. So I just want to start with a thank you to all of you for everything that you do. And anyone who's worked with pharmacists for a while will probably not be surprised to hear that I spent the better part of this week trying to figure out how I wanted to introduce my topic. We tend to be a little obsessive about things. And it occurred to me last night that life had supplied me with material for an introduction to this topic. And I want to share with you, a week ago today, at this time, I was sitting in the hospital across the street at Nebraska Medicine. My 89-year-old grandmother, who was on Eliquis, had fallen down the front steps to her home, the concrete steps, and hit her head on the pavement and suffered a brain bleed. Fortunately for her and us, she's okay. We didn't have any, major complications from that fall. She didn't. But having done anticoagulation management for the better part of 24 years, I have personally known patients who haven't been so fortunate. So anticoagulants are serious business, and despite our best efforts, they remain the leading cause of emergency room visits related to medications and have been that way for a long, long time. They require everyone on the team to work at our best, and that includes you. And so I'm really happy today to be able to provide you some education about how they work and how we can use them more safely. So today's objectives, we're going to talk about the anticoagulating agents used primarily in the outpatient setting. Now I know for those of you who work inpatient as well, these are medications that are used in both outpatient and inpatient. Basically what this means, I'm not going to talk about heparin. We're going to talk about the oral anticoagulants and then the subcutaneous anticoagulants that patients use both outpatient and inpatient a little bit. We're going to talk about the role of anticoagulant therapy, so in what situations are we using anticoagulants. Talk about some of the situations that could necessitate dose changes or increased monitoring in patients who are taking specifically warfarin. That's one of the first anticoagulants that became available. And credit to Corey for the work he does. When I started in pharmacy, only 2 of these medications I'm going to talk about today were available. So, the work that his group does, maybe not related to anticoagulants, but similar work around the country has really brought a whole host of other medications. So we'll talk about the red flags that you need to be on the lookout for with patients taking anticoagulants that would lead you to escalate an interaction to a pharmacist or a medical provider. And then just talk about how you can contribute to promoting the safe and effective use of anticoagulants. So I want to start by just explaining what anticoagulants do. So first want to start with saying we call them blood thinners. You'll hear people say that all the time. I have stopped correcting people because it's just really hard to explain. They actually don't thin the blood. They don't affect blood viscosity at all. We're not talking about gravy and thin gravy, thick gravy. Really the role of anticoagulants is to prevent the blood from forming a clot. So it doesn't affect the thinness or thickness of the blood. It just affects the ability of the blood to form a clot. So we use them in patients who are at high risk of having complications from a clot. So that includes patients with atrial fibrillation, which is the most common arrhythmia that can cause microclots to form in the heart that can then get pushed out when the ventricles beat into the brain and can cause a stroke. We use them in patients who've had blood clots or who have clotting disorders. To prevent clots, a lot of times we use them in patients who have already developed a blood clot, and the important thing to know in that situation is anticoagulants do not dissolve clots. Those are thrombolytics. So we have medications that will dissolve blood clots, but what they do is when patients have a blood clot, they keep that clot from growing larger and allow the body to naturally break down the clot that is already formed. So these are the medications we're going to be talking about today. Warfarin.
Hold on just a second. They all of a sudden lost their sound on there.
Uh-oh.
So now. I'm gonna try again.
Okay, can you hear me now? Oh, and there's an echo. Okay, can you hear me now?
Let me go check those.
They were able to hear. Okay, good. Okay, so the medications we're going to talk about today that we're going to focus on are warfarin, the direct-acting anticoagulant agents, or I'm going to call them DOACs because it's hard to say that. So apixaban, rivaroxaban, edoxaban, and dabigatran. And then the injectable medications, enoxaparin, I'll include actually dalteparin in there as well. Enoxaparin is certainly more frequently used, but there is another low molecular weight heparin called dalteparin, and then fondaparinux. Well, now this won't work.
Did I break it?
we'll get it all to work eventually. Let's see. Let's see. We'll just go next. How about that? Okay, that's fine.
Very good.
Well, yeah, we'll see if it, yes, I can just do that. So this is a slide I'll tell you that like strikes fear in the heart of every medical and pharmacy student. Oh my gosh, like almost PTSD looking at this slide. So I do not expect you to understand all of this. I think there are several points I just want you to take home from this slide. So one is way down here is where the clot forms. Okay, so this whole process is involved in forming a blood clot. And really what I want you to see here is there's two different pathways to the formation of a clot. There's this extrinsic pathway, and that's what happens like if you have a trauma, so you cut yourself, whatever. So we've then followed this pathway down to the formation of a clot. This is called the intrinsic pathway, so like there's a damaged surface. So think of maybe an ulcer or a tumor inside the body that might be bleeding. This would be more a damaged surface would follow this pathway down to forming a clot. But if you'll notice, they both converge right here in this factor 10A to follow this final common pathway to the formation of a clot. And that'll be important when we talk about some of the anticoagulants here later. The other important point I want to make, you can see there's a lot of different clotting factors, right? So it's a pretty big process to get to this point. Most of these clotting factors are actually formed in the liver, so the liver makes these clotting factors. And just an important point here is when the liver is not working well, so patients with end-stage liver disease aren't producing these clotting factors as much as they should be, and so those patients have a predisposition already to deficiencies in forming a blood clot. So we do use anticoagulants in those patients, so if you can think about those patients would be particularly susceptible to complications with anticoagulants because they have this underlying deficiency in clotting factors. So I'm going to start off by talking about warfarin, and I chose this photo because you guys probably already know this, but maybe not. Warfarin is one of just a few medications I'm aware of that actually has color coding by strength, and that color coding carries across to all different manufacturers of Coumadin and warfarin. So it's one of the few medications where somebody can tell you I'm taking the white tablet and you know exactly what they mean. So this can be helpful actually. When you're working with patients, if they can't tell you what strength they're taking, you can ask them what color of the pills they are taking, and that will at least lead you in the right direction to where maybe you could go grab a bottle and show them, and they could tell you yes or no as far as the color. So with this photo, I have a few points I'd like to make. So we call warfarin a vitamin K antagonist, and as I told you, the liver is responsible for manufacturing most of our clotting factors. For the clotting factors 2, 7, 9, and 10 in particular, the liver utilizes vitamin K to produce those clotting factors. And so warfarin works by inhibiting the conversion of vitamin K to this reduced form that then activates the clotting factors 2, 7, 9, and 10 to their active forms. So warfarin blocks this process and thereby blocking this process. The important point I want to make here is it's blocking the production of these clotting factors. What it isn't doing is blocking the clotting factors that have already been produced. So these factors that are out there floating around in the blood are still fully active and still fully working. And some of them, like factor 2, has a half-life of over 60 hours. So that means it's floating around in the blood and doesn't, if we cut off production altogether, it will take 60 hours for the levels of factor 2 to reduce by half. So that's what half-life means. So warfarin's not quick acting. These factors are still floating around out there. It takes a while for their levels to reduce after we start blocking them. So we don't see the full effect from warfarin. Generally, anywhere between, I would say, 5 to 10 days of a patient taking it. So it's not a rapid acting anticoagulant, and that's why sometimes you'll see, and you'll hear me talk about not using anticoagulants together because it increases the risk of bleeding. But that's why you'll see sometimes patients who are on warfarin will use enoxaparin or fondaparinux as what we call a bridge until they reach that therapeutic level of anticoagulation with warfarin, especially if they have a high-risk condition like they've already had a clot. The other important point, so it takes a while to start working. If we stop it, it takes a while for it to wear off. So it takes a while for the liver to reproduce those clotting factors in an amount enough to normalize our ability to form a clot. So it takes a while to start working, and it takes a while to wear off. So what do we use warfarin for? So like I mentioned, atrial fibrillation, it's one of the more common indications for using warfarin. It's also the most common arrhythmia in the population. And atrial fibrillation happens when the top chambers of the heart quiver, and because they're not beating in synchrony, you can form microclots in the atria that then travel to the ventricles and get pushed out into the body and can cause a stroke. We use warfarin. It's the preferred anticoagulant in patients who have particularly non-valvular atrial fibrillation, valvular atrial fibrillation. So patients who have artificial valves or who have disorders with their valves, warfarin is preferred in those patients over the DOACs. We use it in the treatment of DVT, which is deep vein thrombosis, which usually happens in the lower legs, can also happen in the arms, or when one of those clots breaks free and travels to the lungs and can cause a pulmonary embolism. So we can use warfarin in that situation. DOACs are preferred. We'll talk more about that in a little bit, but if we can't use a DOAC, then warfarin certainly would be effective. Patients who have mechanical heart valves, warfarin is preferred over the DOACs in those patients because it's been shown to be more effective at preventing stroke. And thrombophilia syndrome, so patients who have inherited clotting disorders. It's preferred specifically in patients who have a high-risk clotting disorder called antiphospholipid syndrome. Oh, dosing warfarin. This is the art of medicine as much as it is a science. It's sort of a science, I'll say, a pseudoscience. So warfarin, generally, we have to take a guess to what the patient's dose is when we start a patient on warfarin. And so for normal, healthy patients, we'll usually start somewhere around 5 milligrams. For the patients who are more frail, we may do 2.5 or even 1 milligram to start with warfarin. There is no way to know when I look at you what your dose of warfarin is going to be. I couldn't guess, and every person in this room is likely to have a different dose of warfarin. So there's no way for me to know straight out of the gate what dose of warfarin you're going to need. The only way we know what dose of warfarin a patient is going to need is by giving them what we think they need, testing, and testing them. We measure their INR, which Karen's going to talk about after me. We measure their INR. They're either there or they're not. If they're not, we fiddle with their dose and we test again, and we fiddle with their dose and we test again, and we fiddle with their dose and we test again. And then we think we have it right, and then 2 months later it's different. So the thing to take away with warfarin is the dose is not necessarily going to be stable throughout the course of the patient's treatment. In fact, you can expect that it's not going to be stable. And if you can think about the types of patients you see taking warfarin, you could see how that might be problematic. So I mentioned we use warfarin a lot in patients with atrial fibrillation. Atrial fibrillation is a condition that increases as we age. So each successive decade of our life, the incidence of atrial fibrillation increases. So we're using warfarin in patients who are inherently going to be on a lot of medications, who have a lot of medical conditions, who maybe are not mentally at their sharpest in their life, and we're changing the dose all the time. So you can just see, where sort of warfarin inherently can be a difficult medication to work with, and why we were so happy when the DOACs became available. So, according to Copilot, there are 682 drug interactions with warfarin. Whether that's true, I don't know. I can tell you for sure that is probably pretty close. There's a lot. And these drug interactions I've highlighted here are some of the more common and severe interactions we see with warfarin. But it's a pretty safe bet that a medication in a patient who's taking warfarin, when it gets added on, that there's likely to be some sort of interaction. So when we start warfarin and a patient is taking, so say I have a patient who's taking phenytoin and we start warfarin, we adjust for the fact that they're on phenytoin straight out of the gate. So I'm adjusting for the medications they're currently taking when they start warfarin. Where we run into trouble is when we add new medications or take away. So they were on phenytoin and maybe that then got changed to something else. That interaction goes away and that will affect the INR. So anytime we add or subtract medications, 682 medications, can affect warfarin and affect the INR and sort of the risk the patient has of having complications from warfarin. So drug interactions are huge with warfarin. NSAIDs and antiplatelets in particular don't necessarily affect the INR a whole lot, but they will increase the patient's risk of bleeding because they also can have effects on bleed risk, obviously. Antiplatelets actually are not anticoagulants, so these are aspirin, clopidogrel, Brilinta. We do use them sometimes with warfarin, and that does increase the patient's risk of bleeding. So they have a different mechanism outside of that clotting cascade and how they work, but they do increase the patient's risk of bleeding. NSAIDs can block the production of protection in the stomach, of compounds that protect the stomach from GI bleeding. So taking NSAIDs with warfarin can increase GI bleed risk. The other big thing we see with warfarin in terms of drug interactions, I already mentioned, it works through vitamin K, right? So it's a vitamin K antagonist, and one of the ways that we can overcome that is to give them more vitamin K. So obviously vitamin K that patients would take in through vitamins or their diet can affect warfarin. Foods that are high in vitamin K we think of as the green leafy vegetables, so lettuce, kale, spinach, and then other green vegetables like broccoli, Brussels sprouts, all the things that are good for you. Patients will have the impression that they're not supposed to eat those things and they'll avoid them. I don't tell patients to avoid them. The key, they're healthy. They're a healthy component of our diet. I want people to eat them. The important thing with warfarin is that the diet stays stable. So where we get into trouble with diet and warfarin is when patients make big changes. So if they don't eat a salad every day and they all of a sudden start eating a salad every day, or they weren't taking a multivitamin with, that had vitamin K in it, and they start taking it, a multivitamin with vitamin K. Even the nutritional supplements like Ensure, Boost. I've had people come home from the hospital and, trying to get back on their feet again and starting to drink things like that, contain vitamin K and can affect warfarin. So lots and lots and lots of things can affect warfarin, and it's why we monitor so frequently. Generally, again, Karen will talk about this, but we monitor the INR a lot at first, and then once we get them stable, generally it's a monthly lab. But if any one of these factors change, we can see some instability in the INR and start having to make dose adjustments and checking the INR more frequently. So pros and cons with warfarin. It's old, it's been around for a long time. It's cheap, cheap, cheap. So I think it's on, I don't know, anybody work at Walmart? It had been at least on their $4 list. I don't even know if it's a $4 list anymore. Is it 10? I don't know. But it's inexpensive. So low cost. It's pretty easy to reverse. So it's a vitamin K antagonist. For those of you who have worked in pharmacy for a long time, we can give vitamin K to reverse its effect. We don't do that as often as we used to anymore, but it's pretty easy to access vitamin K. So it's easily reversible. Like I mentioned, it's preferred in patients who have artificial valves and antiphospholipid syndrome. So it's been shown to be more effective in those patients versus the direct-acting oral anticoagulants. And the nice thing about it is, despite all its drug interactions, we can adjust the dose to manage those interactions. So you're going to see when I start talking about the DOACs that they also interact with medications like phenytoin. And the downside with those is we can't adjust their dose to account for that interaction, so we just recommend that we don't use them together. We can use warfarin in that situation because we can adjust for it. Cons should be obvious. The frequent monitoring, lots of drug interactions. It's affected by diet changes, like I said. Illness is another big factor with warfarin. So think about when you get sick. Aside from the fact that you're sick, you eat differently. That can affect your INR. They do carry a higher risk of bleeding, especially when the INR is unstable. So the DOACs have shown lower risk for bleeding in the central nervous system versus warfarin, and that's primarily, again, when the INR is unstable. The DOACs tend to be more stable. We give one dose, and we get a consistent effect. The other important thing to know about warfarin is it's contraindicated in pregnancy, so it's been shown to be teratogenic, and so in younger patients taking warfarin, we do recommend that they use a reliable form of contraception. And like I said, they have it as a slower onset to full efficacy, somewhere between 5 and 10 days. And same thing with stopping it, a slower effect to wearing off. So here's where that big ugly slide comes in handy. And I'm going to talk about the DOACs. So I mentioned, we have those two different pathways coming down here, and they converge here on factor 10, and that becomes the final common pathway to forming a blood clot. So, while warfarin works on clotting factors up in here and the formation of those clotting factors, our direct-acting anticoagulants work primarily on inhibiting directly factor 10A or thrombin. So dabigatran was actually the first direct-acting oral anticoagulant, and it's a direct thrombin inhibitor. So it goes in and inhibits thrombin directly. So it inhibits the formation of a clot by inhibiting this step right here. The medications edoxaban, apixaban, rivaroxaban, I want to point out, notice the XA, if you haven't ever noticed that before, are anti-10A. So they work directly by inhibiting factor 10A, and that inhibits this step just a little bit higher up than thrombin. So it inhibits the conversion of prothrombin and on down. So they come in and they work on all those clotting factors that are already out there. So we're not relying on those clotting factors to be produced. They just work on whatever's floating around. So indications for DOACs, pretty similar to what we see with Warfarin, with a few exceptions. So like I mentioned, they're recommended for patients who have atrial fibrillation as long as they don't have valvular disease or artificial valves. So they're all approved for non-valvular atrial fibrillation to prevent stroke. They can be used and are actually preferred in clotting disorders, or not clotting, I'm sorry, in blood clot treatment, so DVT and pulmonary embolus. Apixaban and rivaroxaban can be used straight out of the gate. Both dabigatran and edoxaban do require an initial bridging period with parenteral anticoagulants. We use them for post-surgical prophylaxis of blood clots related to patients being immobile and just having surgery, which are risk factors for developing a blood clot, because they work quickly. We used to use Warfarin and then bridge them with enoxaparin, and now the standard of treatment is to use a DOAC. Rivaroxaban also has this additional indication for combined with aspirin to reduce cardiovascular risk in patients with peripheral and coronary artery disease. So again, pretty similar indications to what we see with Warfarin. As far as dosing, the nice thing about these is we put them on a dose and we don't have to fiddle. So as long as we put them on the right dose to begin with, we're usually pretty good. And as long as we monitor for renal function, all of the direct-acting oral anticoagulants are eliminated to some degree through the kidneys. And so we do have to be mindful of patients who have kidney disease that we're dosing those appropriately. Apixaban actually has the most leeway in terms of most forgiveness, I'll say, in patients who have kidney disease. So that tends to be the one that we prefer in patients who have some renal dysfunction, and it actually has been used all the way down to dialysis. So again, with the DOACs, it's mostly just noticing that does the patient have kidney disease straight out of the gate, and then monitoring for the development of that over time. And that probably, in my experience, has been our biggest, I'll say, miss in terms of using the DOACs, is just sort of forgetting to watch for the fact that patients do tend, as they age, to develop reduced kidney function, and just making sure we catch that in time and reduce the dose when we need to. The other issue with DOACs can be when they first came out, they weren't recommended in patients who were obese. We didn't have a lot of data, and there wasn't good information to tell us whether they behave similarly with the same dose, right? Because we use a standard dose in patients who are obese. We have more data now, and so they are considered okay to use in patients who are obese. There's still some controversy, and guidelines recommend against using them in patients with a BMI over 40, although there's some data to show now that they might be safe. I can tell you, I personally have seen DOAC failures in patients who are obese. So I think there's still some questions out there about safety in that population. Elderly, you're going to hear any medication. The elderly are more susceptible to adverse events. That's Warfarin, a DOAC, any medication we use. The thing that makes the elderly particularly sensitive to anticoagulants is they also tend to be the population, again, that's going to be on the most medications, have the most concern for drug interactions, most likely to have kidney disease. And so really as a patient population, we need to watch carefully when we start and while they're taking anticoagulants. So interactions with the DOACs, there aren't as many as there are with warfarin, and that's wonderful. Some of the drug interactions between the two are similar, but medications like phenytoin, carbamazepine, those medications can induce the metabolism, meaning that they over-metabolize the DOAC medication and then have a reduced effect from it. So because of that, we recommend against using DOACs in patients who are on phenytoin and carbamazepine. Medications that can increase the effect of a DOAC, fluconazole, amiodarone, you'll notice were similar to what we saw with warfarin. And the downside is we have no way of really adjusting or monitoring for those interactions. And so we tend to try to just avoid using them together. So antiplatelets and NSAIDs, that's going to be a contraindication or recommend against, basically, for any anticoagulant. And it's just important, I think, just take away with both warfarin and the DOACs that we just need to know what other medications they're taking, right? So if you have a patient coming in, they're filling warfarin and maybe you don't have a good medication history on them, it is really important, you know, if they don't regularly fill at your pharmacy to find out what else they're taking. Don't rely on the person who prescribed it to have done that. So I really do encourage, you know, if you have a patient bring in a prescription for a DOAC or warfarin, and maybe you aren't familiar and you don't see that you have a lot of medication history on that patient, it is really important to know, because providers, I have seen providers prescribe DOACs to patients on phenytoin. So if they fill phenytoin at another pharmacy, you may not know that. So always ask. Pros and cons of DOACs. So we don't monitor DOACs. We put them on a dose and we go. They've proven that they're effective across a wide range of patients. We know what the dosing adjustments are needed for renal function and for age. So we just put them on dose and we go, and then we monitor their renal function over time. But there's no specific monitoring and fiddling with their dose like we have with warfarin. They have a quick onset and quick offset, and that makes them particularly nice in situations where we want a rapid effect. So they've got a blood clot, and I want something that's going to start working right away. These are really nice medication to use in that situation. Or they're going to have surgery, and we don't have to stop them a week in advance for their surgery. So we can stop them quickly, we can start them quickly, on and off real quick. They have fewer dietary restrictions, and they have a lower bleeding risk, especially, again, when the INR is unstable. The downside, they're expensive. They're a newer medication, so cost can be a barrier, and that's sometimes why we end up using warfarin, even in situations where we know these might work better. They have limited reversal agents. So I mentioned vitamin K is pretty easily accessible. The reversal agents for the DOACs are really expensive, and if you live in rural areas especially, rural hospitals may or may not have them. So if we have patients who live in rural areas and they were to have an accident, we would have to rely on getting them maybe to a larger city to get access to the medications that could reverse their anticoagulation. So in terms of contraindications, we don't use DOACs in patients who have mechanical heart valves. They've actually shown a higher risk of stroke versus warfarin. So fingers crossed that we have something coming down the pipe for that situation. But for right now, for patients who have mechanical heart valves, we use warfarin. Same thing with antiphospholipid syndrome. So there have been too many DOAC failures in that condition, so warfarin is still recommended in those patients. So in looking at the injectables and their mechanism of action, pretty similar to what we see with the DOACs. I will add here, so fondaparinux doesn't directly, it's sort of upstream, has an effect on 10A, but its ultimate effect is inhibiting factor 10A. Enoxaparin and dalteparin are low molecular weight heparins, and they work by inhibiting factor 10A, and they also have some effect here on thrombin. So enoxaparin is used primarily, it can be used in similar conditions as warfarin and the DOACs. Obviously, patients don't like to give themselves injections every day, so we tend not to use it long term unless we have to. They're painful injections. I've actually had to give myself enoxaparin, and it stings. It's not fun. It causes a lot of bruising at the injection site. Patients hate using Lovenox. So it tends to be used for short time periods only. So we use it prophylactically in patients who are at risk for thrombosis after surgery or if they're immobilized. We use it, again, I mentioned bridging with warfarin. So if we were to start warfarin in a patient who already had a blood clot, we want something that's going to work right away. And so we'll use enoxaparin in that situation to bridge the patient, meaning provide them with therapeutic anticoagulation until they reach full therapeutic effect of warfarin. Why don't we use the DOACs for this, right? So I just talked about all these medications that work quick on, quick off. So why are we using an injectable in that situation? And the bummer with the DOACs is if you check an INR in a patient on a DOAC, sometimes the DOAC can interfere with that INR result. So we can't trust the INR result we get in patients who are on DOACs if we were using those to bridge onto full therapeutic warfarin. So that's why we use enoxaparin in that situation. Dosing of enoxaparin generally based on a patient's weight and renal function is also a consideration. So it is dose reduced for patients who have renal disease. The final point I want to make about the low molecular weight heparins, I mentioned that warfarin is contraindicated in pregnancy, or highly unadvised, I'll say, in pregnancy. The DOACs don't really have enough data to support their use, so the low molecular weight heparins are what's recommended in patients who need anticoagulation during pregnancy. Fondaparinux, mostly what I want to say about that, I think this medication exists mostly for patients who have heparin allergy. We need to have something for those patients. It is real, it does happen, and I have one patient actually who does have heparin allergy, and I'm really glad that this is available. So, similar indications to enoxaparin, also quick on, quick off, can be used in kiddos. And like I said, mostly we use this in patients who are allergic to heparin. So all of the anticoagulants obviously are going to increase your risk of bleeding. And red flags we need to watch out for in patients who are taking anticoagulants. Signs and symptoms of bleeding. So what that looks like, any form of blood in the stool. So bright red blood tends to be from lower down in the GI tract. Bleeding from higher up in the GI tract tends to be darker. So it'll present in the stool as looking like black tarry stools. If the patient were to vomit and had bleeding in their stomach, it would look like coffee grounds. So any bright red blood, dark tarry stools, vomiting that looks like coffee grounds, those are indications of bleeding within the GI tract, and that's an emergency on anticoagulation. Any form of bleeding that they can't get to stop. So oftentimes in the winter, I'll get patients who get nosebleeds from the dry air. A lot of times, we'll tell them, go ahead and provide some compression, maybe put some an ice pack and compress to stop that bleeding. If they can't get it to stop, usually they'll end up in the ER and maybe they'll cauterize and help with that. They're not going to bleed to death, but you know, it's still an issue. So any bleeding that they can't get to stop, or any unprovoked, especially large bruising, you know, bruises that continue to grow or particularly painful, those would be signs of a problem on a patient who's using anticoagulation. To assume that anticoagulants are 100% effective would be a mistake. So we also have to watch for signs and symptoms of the very thing we're trying to use them for. So in patients with atrial fibrillation, they can not only have a stroke still from a microclot, they still happen. We're just reducing the likelihood, but they can also have a stroke related to bleeding. So signs and symptoms of stroke, so numbness or weakness, change in vision or ability to speak, even if it's temporary, and that's a really big thing. You know, you'll hear patients, they'll tell you, man, I hear this all the time, they'll tell you, last week I had this time where I, you know, was talking to my friends and all of a sudden I just lost my words. And, you know, about 5 minutes later it came back, and they're telling me this a week later. That can be a TIA. And a TIA, so it's temporary interruption, so that can be a sort of microclot that has caused a temporary loss of function. That can be a harbinger of a bigger event to come. So even if it's temporary, if somebody tells you they've had something like that, they need to be evaluated right away. Signs or symptoms of a blood clot. Again, don't assume that just because they're on an anticoagulant, this can't happen. I've definitely seen breakthrough. In fact, this just happened with one of our patients a couple weeks ago. So blood clots will present as pain and swelling, usually in a single limb. So unilateral pain or swelling, redness, warmth in a leg, or shortness of breath, meaning that clot may have broken free and traveled to the lungs. So like my grandmother, injuries and falls, especially if they hit their heads, always, that's an immediate ER. I don't care if at the moment they're feeling fine. Bleeding with warfarin can change on a dime. And so the important thing is that they get evaluated and make sure that they're treated appropriately. With my grandmother, she went to one hospital, ended up getting transferred here because they didn't have the reversal agent at the initial hospital she went to. So it's really important that they get here and they get care. And then it's just important to know any patient who's had a bleeding event are at higher risk of having another one. So if they've already had one bleed, just be aware they're more likely to have another. So what this looks like, this could be a typical patient maybe that comes in. A 60-year-old man with a history of peptic ulcer disease. He has hypertension, diabetes, atrial fibrillation. He's on apixaban twice a day. He's picking up his refills, and he tells you that his stomach's been acting up, not been feeling great. Just hasn't been feeling well, kind of lightheaded, doesn't have much energy. Notice that his stools have been very dark, almost black. So I would hope that you would escalate this and either ask them to seek medical attention or bring on the pharmacist to talk to them some more about this situation. And what I personally would do is I would tell this person to go to the ER. And he might be taking Pepto-Bismol, which can cause black stools. Even if he told me that he was taking Pepto-Bismol, I would still tell him to go to the ER. So GI bleeds are the leading cause of bleeding in patients who are on anticoagulants. So anticoagulants are the leading cause of medication-related ER visits. GI bleeding are the leading cause of bleeding. So GI bleeds are really common in patients on warfarin if they're going to have a bleeding event. Again, they can change on a dime. So this guy might be fine for 2 hours, he might be fine for 2 days, he might be fine for 2 weeks, and he might never have an issue. But because I don't know that, 2 hours from now, that GI bleed might accelerate into a life-threatening condition. I'm gonna send this guy to the ER. If he goes to the ER, these are the reversal agents that they would most commonly use. Notice Warfarin, vitamin K. Again, we tend not to use vitamin K for life-threatening bleeding. It's not going to work quickly enough. So vitamin K is primarily used for patients who have really excessively high INRs, and we're worried about them having a bleed, so we may give them vitamin K to reverse warfarin in that situation, but otherwise they're getting fresh frozen plasma or this Kcentra. So I'm not going to talk a whole lot about these. These are administered mostly inpatient, but just know the agents to reverse both dabigatran and the 10A inhibitors are really expensive, and they're not everywhere. So patients in rural areas may not have access to these medications. The other thing I want to point out is notice there's no fondaparinux on here. It actually does not have a reversal agent, so it's important to know with that. So I have a case study that hopefully we'll get some participation. So we have Miss James. She's 84. She has atrial fibrillation. She's taking warfarin for stroke prevention and has prescriptions for 1 milligram, 2.5 milligram, and 4 milligram tablets, which I would never do in an 84-year-old because her INR has been unstable. She's required frequent dose changes. Her medical history is significant for chronic renal insufficiency, osteoarthritis. She has some mild cognitive impairment and hypertension. She takes losartan, memantine, acetaminophen, and warfarin, obviously. She uses a walker due to chronic hip pain and unsteadiness. So what factors, in this case, do you think would place Eleanor at particularly high risk for adverse effects from anticoagulation? Thoughts? Sentence one.
Having too many doses of the warfarin available to her because of her mild cognitive impairment.
Yep, agree, 100%. So when I'm working with patients on anticoagulation management, we try to stick to one dose and adjust using that one dose. So you might see patients not taking the same dose every day, and that in itself can get tricky in patients with cognitive impairment. But when you start introducing other strengths, you just add a whole other layer of complication. Yep. Other thoughts?
Her age.
Yep, her age, right? So elderly are at higher risk for adverse events related to anticoagulation. What else? Right. So patients with renal insufficiency are at increased risk. Basically, rule of thumb, the more disease states a patient has, the higher the risk they are. But renal insufficiency in particular is one that can be an issue. What else?
Fall risk.
Exactly, right. Yeah, think about what I opened with. Yeah, so fall risk, right? So she's a fall risk. Let's see, what did I miss? Cognitive impairment I would put on there. I mean, you mentioned that, but yeah, a patient who has cognitive impairment is more likely to get dosing wrong. So what would I do for that, and what kinds of things would you do for a patient like this? I guess the first thing I'll say here is just pay attention, right? Get to know your patients. That's probably as important as anything you do. Just pay attention, notice. Adherence monitoring, super important. If they feel Eliquis, they got a 30-day supply and they're picking it up after 40 days, ask them, hey, did you have to stop that for any reason? Did you have a procedure? I noticed you filled this 40 days ago. Have you had any issues, trouble remembering your medications? Finding out what other medications they're taking. Just helping with adverse effect monitoring. Doesn't mean you have to sit there and ask them, about signs and symptoms of bleeding every time you see them. But, if they're mentioning things to you that are raising red flags in your mind, those are definitely worth passing on. Dosing verification, again, making sure patients know that they're asking for what they really need. So like this gal who had 3 different prescriptions for Warfarin, and she hasn't filled her 1 milligram tablets for 6 months, and now all of a sudden she's asking for a refill. Ask, what dose are you taking now? And if they can't tell you, what color do your tablets look like? Things like that. If they can't answer those questions, also, do you use a pillbox? Just simple questions like that can really make a big difference with patients. And then just, like I said, getting to know your patients, asking, their medical history, looking at the other medications they're taking and what that might imply in terms of their medical history if you know that. So all things, basically, like I said, pay attention, It may not be necessarily something you think of as your job to catch stuff like this, but I've got so many things as a pharmacist that were not within my realm of things I was working with a particular patient that have still made a big difference with patients. So I know you guys can do the same. So just to summarize, the anticoagulants work to prevent new blood clots from forming and prevent extension of current clots. All sorts of different conditions, medications, diet, adherence, obviously can all play a role in anticoagulation outcomes. And you guys are an important piece. Every member of the team is important in preventing adverse outcomes with patients on anticoagulants. So with that, I will take any questions. Yeah.
Where would you, does the COX-2 inhibitors interact with Coumadin? I have questions, sorry.
Yeah, yes. They do. Yeah, we usually discourage all non-steroidals. Celecoxib actually can even increase the INR, interact to increase the INR. Yeah, I mean, they decrease the risk of GI bleeding relative to other NSAIDs, but it's not zero. So
how about with I'm sorry, I use brand names.
Yeah, no, that's fine. Go ahead.
Eliquis,
Mm-hmm.
does that have an interaction with the other ones? The dose?
Oh, celecoxib? Yeah, I would tell a patient, it's even on, sorry, yeah, I was mentioning warfarin in particular, but yeah, I would say any anticoagulant, we discourage NSAID use altogether.